Good afternoon, folks. This afternoon's topic A: why America pays more for worse health and why we can't pretend it's normal. Okay, so we'll dig into that for today's A. Please join me. Here we go. American healthcare has become a global outer and not the way a nation that prized itself on innovation should hope. We spend nearly 18% of our GDP on healthcare, almost double the average of other high income nations, yet deliver shorter lives, higher maternal mortality, thinner primary care infrastructure, and deeper inequities than any of our peers. This is not a mystery. It is a policy choice. Other wealthy nations have built systems designed around people. We have built one designed around prices. The global comparison is not flattering. Across the OECD, countries like Japan, Switzerland, and the Netherlands, and Norway achieve life expectancies of 82 to 85 years. The United States, hovers around 79, and in many communities, rural community rural counties, Black and Indigenous populations, and regions hollowed out by economic decline. The average is far lower. Avoidable mortality tells avoidable mortality tells an even sharper story. The US ranks second worst among high income nations, meaning Americans die from conditions that other countries routinely prevent or treat. This is not because Americans are sicker or use more care. It is because the care they need is harder to access, more expensive, and less coordinated. The price problem, the defining feature of American health care, is not overuse, it is overpricing. A hospital stay costs 2 to 3 times more here than in peer nations. Prescription drugs cost more here than anywhere else in the world. Even basic imaging, an MRI, A CT scan can cost 5 times as much as the same scan in France or Australia. Other countries regulate prices. We negotiate, but only in fragments. And when negotiation fails, we simply shift the cost to patients through deductibles, coinsurance, and surprise bills. The result is predictable. Americans skip care at the highest rate among wealthy nations, even when insured. The workforce problem. The United States has the fewest primary care physicians per capita among high income countries. We have built a system that rewards specialization and procedure volume while, while starving the front line of care, the clinicians who prevent disease, manage chronic illness, and anchor aging populations. Other nations treat primary care as infrastructure. We treat it as optional. The consequences are visible in emergency departments, in late stage diagnoses, and in the revolving door of hospital readmissions. They are especially visible in rural regions like northwestern Pennsylvania, where access to dementia care, home health, and hospice is increasingly fragile. The equity problem. No other wealthy nation tolerates the level of health and inequity we do. Life expectancy can vary by 20 years, depending on zip code. Maternal mortality for Black women is 2 to 3 times higher than for white women. Native communities face chronic underfunding and structural barriers that no peer nation would accept. Universal coverage is not panacea, but it is a foundation. The US remains the only high income country without it. Long term care problem. If you want to understand the American healthcare paradox, look at long term care. Other nations treating Other nations treat aging as a collective responsibility. We treat it as a private burden. Families drain savings, leave the workforce, and navigate a maze of frag- fragmented services. Medicaid, our largest long term care payer, requires people to become poor before receiving help. No other wealthy nation structures elder care this way. What high performing countries do differently across the world's best systems. Five themes repeat: universal coverage with regulated pricing, strong primary care with real gatekeeping, low administrative overhead, national investment in prevention and social supports, workforce planning tied to population needs. These are not radical ideas. They are the baseline of modern health systems. What America must decide. The US is not doomed to underperform. We have world class clinicians, leading research institutions, and under undermatched biomedical innovation. But we also have a financing system that under undermines all of it. We can continue we can continue pretending that our outcomes are an accident, or we can acknowledge the truth. The structure of America American healthcare is producing exactly the results it was built for. If we want different results, longer lives, lower costs, more dignity in aging, more equity across communities, we must build a different system that begins with the political courage to say what the rest of the world is already what the rest of the world already knows. Healthcare is a public good, and the United States cannot afford to treat it as anything less. Care physician who can who has seen the consequences of policy failure up close. US America's healthcare crisis is not an accident. It is a choice, and it is time to stop choosing failure. The United States spends more on health care than any nation in human history. We spend nearly 18% of our GDP, almost double what other wealthy countries spend. And what we do, what and what we and what do we buy with it? Shorter lives, higher maternal mortality, thinner primary care, deeper inequity. No other high income country performs this poorly. None. This is not a glitch in the system. And this is the system. We are paying premium prices for bargain bin outcomes. Across Europe and Asia, life expectancy climbs into the mid 80s. In the United States, it stalls around 79. And in many communities, especially rural counties and communities of color, it plunges far lower. Avoidable mortality, deaths that should never happen in a functioning health system, is second worst among peers and among peer nations. Americans die from treatable conditions because care is too expensive, too fragmented, or too hard to reach. Other countries have built health systems. We have built a health marketplace. The price problem is a policy failure, not a mystery. Let's be blunt. American healthcare is unaffordable because we allow it to be. Hospital stays cost 2 to 3 times more here than abroad. Prescription drugs cost more here than anywhere else in the world. Even basic imaging, an MRI, a CT scan, can cost 5 times as much as the same scan in France or Australia. Other nations regulate prices. We regulate people through deductibles, coinsurance, and medical debts. Americans skip needed care at the highest rates among wealthy nations. Not not because we don't not because they don't value their health, but because they can't afford it. The workforce crisis is a structural failure. The United States has the fewest primary care physicians per capita among high income countries. We have built a system that rewards procedures over prevention, specialization over continuity, and volume over relationship. Other nations treat primary care as the backbone of their system. We treat it as an afterthought. The consequences are everywhere. Emergency departments overflowing, chronic disease unmanaged, dementia diagnosed too late in and rural communities, including those in northwestern Pennsylvania, left without basic basic access to care. The inequity crisis is a moral failure. No other wealthy nation tolerates the level of health inequity we do. Life expectancy can swing 20 years depending on zip code. Maternal mortality for black women is 2 to 3 times higher than those than for white women. Native communities face chronic underfunding that would be unthinkable elsewhere. Universal coverage is not a luxury, it is the floor. And the United States is the only high income nation that refuses to stand on it. Long term care, the clearest indictment of American policy. If you want to see the American healthcare healthcare paradox in its purest form, look at long-term care. Other nations treat other nations treat aging as a shared responsibility. We treat it as a private burden. Families drain savings, leave jobs, and navigate a maze of fragmented services. Medicaid, our largest long term care payer, requires people to become poor before receiving help. No other wealthy nation structures elder care this way. This is not just insufficient and inefficient, it is cruel. The world has already shown us what works. Across the highest performing systems, five principles repeat: universal coverage with regulated pricing, strong, strong primary care with real gatekeeping, low administrative overhead, national investment in prevention and social supports, workforce planning tied to population needs. These are not radical ideas, they are the global norm. America must decide what kind of nation it wants to be. We have world class clinicians, extraordinary researchers, and unmatched biomedical innovation, but we also have a financing system that underestimates all of it. We can continue pretending that our outcomes are accidental, or we can admit the truth. Our policies are producing exactly the results they were designed to produce. If we want longer lives, lower costs, more dignity in aging, and real equity, we must stop thinking, stop tinkering around the edges. We must rebuild the system, not patch it. The rest of the world has already shown us the path. The question is whether America has the courage to take it. Okay, guys, that is A for you. Tonight I will do B for you this evening. About I'll be back about 9 o'clock on tonight, so I will see everybody at 9 for B. For now, Gator Wellness, take care, folks.